insulin discovery. And in the next 15 minutes, I would just enumerate the events that have predominantly taken place to refine from a crude state of insulin availability and non-availability to availability to the current state of affairs that we have in the insulin space. Just look at this first slide and look at the middle part of it. What does it say? It's a prescription for a type 1 diabetic. Protein 7 grams, fat 6 grams, carbohydrates 15 grams, and calories 150. And look at the kid in the lap of the mother on your right. Does it surprise you that whether this kid dies of diabetic ketoacidosis or dies of starvation when he is given calories of 150? Because at that given time, just 100 years back, the most effective treatment that was put in place for even type 1 diabetes mellitus was strict diets with minimal carbohydrates. And that is where we start from in the earlier part of the last century. Banting was working in a town known as London in Ontario, Canada. And this plaque commemorates the discovery which gave hope to all these guys, including those kids that you saw in the previous slide. If we look at the sequence of events, you can just see how things have moved in these 100 years. July 1st, 1920, Banting starts his practice in Ontario, Canada, and he starts developing the idea about the role of beta cells in diabetes and pancreas. The concept of beta cells that time was not refined as it is today. Basically islets. And he joins in November 1920 MacLeod in his lab. The lab belongs fundamentally to MacLeod for finding out what is happening with pancreatic extracts. In 1921, May, they begin their first experiment. Banting begins his first experiments with Best. And by 30th of July that year, the crude activity of the pancreatic extract is shown in the animals, particularly in the dogs, that has an activity that is capable of reducing the blood sugars and restoring some amount of metabolic normality. In June 1922, this whole gets better conceptualized, and the data stands published a couple of months later, and then Eli Lilly moves in to get the first rights on this particular substance, which had still been was in a very crude form. And Banting and MacLeod were awarded Nobel Prize in the following year. Slide seems to have got a bit frozen.
Sir, can you just try minimizing and maybe opening again, sir? Or you can just click the Windows key on your keyboard once. Yeah.
These are the guys, who contributed maximally in that first couple of years. Banting Best, the clinician part of it, and Collip and MacLeod, basically the chemist part of it, the biochemist part of it. And you can see on your lower side of the slide on the left, These were some of those initial vials that were made in the labs in Scandinavia. Now, if you look back over the 100 years, in 1921 in Toronto, the concept of insulin gets institutionalized, that there is a substance in the pancreatic extract, islet cell extract, that has the potential of reducing the blood sugars. And in 1922, August and Mary Krog, who were at that time first, traveling in Yale University on a lecture tour, from there hop on to the Ontario, Canada, and acquire the rights to produce this extract in Denmark, Scandinavia. And they produced this molecule in Novo Nordisk labs in 1923. And this became available the same year, first in Scandinavia and then in the rest of the other countries. Now, just this is amazing thing that many of the youngsters of the current day would not visualize, cannot visualize. Look at 1913. You look back at the first slide that I showed you, look at that young kid, and look at his status. So if you imagine now a boy at that time, when life expectancy on an average globally, particularly in the Western world, was 54, you would hardly add an year or two to a person's life who had type 1 diabetes mellitus. And by 1945, when insulin was already available in the market for more than one sources, and in the Western world, life expectancy was 66. Availability of insulin to these type 1 diabetics had already added more than 35 years to their credit. And today, you know what an amazing difference that insulin is making to the lives of millions of individuals, whether with type 1 diabetes mellitus or type 2 diabetes mellitus. And how many million years of life every year this molecule or these molecules are adding to the life of people. Apart from whatever Banting and Best did, it was in 1926 that first time able crystallized insulin. Insulin was available, was literally regular insulin because it was a crude direct insulin from the pancreatic islet cells. And he developed a technique by which you could crystallize it. And almost a decade later, Hodgkin actually took a three-dimensional X-ray photograph of the insulin crystals, for which he was also given a Nobel Prize. And then people started saying that, is it possible that we can mechanize this molecule in such a fashion that we can give it a little bit less frequently? Because otherwise, every time you would have given the insulin that was raw coming from the pancreatic extract, it would work for 2-3 hours. So then people started experimenting with different substances, protamine, zinc, globin, surfin, isofan, and then ultimately the NPH and which was Hagdon one and the Lenti one that came to the market, and then ultimately the combination of 30 and 70 formulation, where you had a 30% of a regular insulin and 70% of a relatively longer acting insulin. Now, if you look back at the innovations during all this period, and I think one of the innovations that was most important in improving the quality of the insulin is that in ensuing decades will make it to the market, was the work of Sanger in late 1950s when he deciphered the amino acid sequence of A and B chain of insulin. And that created the concept of proteomics, and then people started understanding the dynamics of different parts of this molecule so that you could customize in the lab over the years to come, creating newer and better and more predictable insulins. Gödel first time gave the concept of recombinant human insulin, which made, prior to that, you would only get insulin from bovine and porcine sources. So there will always be limitations of sacrificing those animals or getting those many actual pancreases for extracting insulin. But when the recombinant DNA concept came in, you could get ad librum any amount of insulin at any amount of the time. And it was in 1982 that Eli Lilly created in the lab the first recombinant insulin. And we had in 1996 Lisipro, the first analog available. I still remember it was launched in India, and the first launch meeting occurred in Goa decades back. And then immediately, a couple of years after that, insulin aspart. And then it started a huge tirade. And one of the first longer acting insulins that made big in the market was Glargine. And then came Detamar. And recently, about 3/4 of a decade back, all of us have seen the amazing properties of insulin degludec, longer acting insulin, and then its combination with the shorter acting formulations and now ultra short acting insulin that made it to the market. So in brief, if you look at this whole phenomenon, one of the after the crude extract of insulin that was available with Banting and Best's methodology, three major events were discovery of the mechanism of prolonging the action of this insulin, and it started with protamine zinc. And then second most important landmark discovery was the concept of recombinant human insulin, so that you could create it ad librum within the lab. And then came the concept of insulin analogs, which totally changed the way we practice diabetology today. You have now a very long-acting insulins, you have a very long-acting insulins, you have a short-acting insulins, you have ultra-short-acting insulins, and I'm sure the way the work is going on some of the insulins, in a year or two, we might have a weekly insulins. In the last 1 decade, we had this degludec in 2013, Tresiba, then Rizodec, and then we had the more denser version of Glargine, Toujeo, and then launch of an ultra-short acting insulin. Just works like a true endogenous human insulin. So if we look back over these 100 years, the only thing that was available and the best thing that could happen was availability of animal insulin 100 years back. Today we have barrages of molecules to take care of this healthcare issue, which is not only a global issue, but is a major economic issue given the number of people who have diabetes today and the amount of money that is needed to keep such people in good health. So in summary, one thing is very clear. In our quest to treat our patients better, ever since the insulin was discovered, the road ahead was full of innovation so that, we could customize the treatment to the requirements of a particular patient. During this period, we understood diabetes better. We understood the pathophysiology of the disease better. We understood the structure of the molecule. We understood the areas which were functionally potent, which understood the areas which were important for getting tagged on to a receptor. So today, we are really privileged to have so many insulins available with us, so many modes of treating diabetes with us. I still remember, and I'm sure Chandalia Saab would remember it far more than us, and Prasanna, Kumar and me did so many meetings in 80s, so that frame of the mind of the clinician and the patient changes towards taking a treatment which is more reasonable, which is more rational, and which is more physiological. That is taking insulin when it is needed. And I think all of us need to do that shifting of the thought process, both the patient as well as the clinician, that sooner that insulin is given to contain dysglycemia and dysglycemia related complications, the better for the patient. The sooner we find out that appropriate insulin molecule that is good for our own patient and institute that therapy, the better in totality for the patient population. Thank you so much.
Thank you so much, Abdul Zargar sir, for giving that beautiful exposition about 100 years of insulin innovation. You told us right from the October of 1920 when Dr. Banting conceptualized the idea of giving a purified form of insulin for the for use in patients with diabetes until the present day of 2020s. What sort of innovations have taken place? I think it has been a continuous journey of innovation that you have nicely walked all of us through. Thank you so much for that. I would like to remind all the participants who have joined in for today's meeting. I can see that there are close to 1,000 participants who have already logged in. I would like to remind all of them that please post your questions in the question box or the chat box so that they can be taken up by the speakers during the panel discussion. Now it is my pleasure to invite the second speaker for today's session. It is none other than Dr. K.M. Prasanna Kumar sir. So thank you so much for being here with us today to talk on a very important topic, making insulins more patient-friendly, a review of scientific advancements in insulin delivery. Dr. K.M. Prasanna Kumar sir is a senior endocrinologist from Bangalore. He is practicing in Center for Diabetes and Endocrine Care in Bangalore. Sir, over to you to walk us through the second topic for today's discussion.
You may share screen, please.
Yes, sir. We can see a screen, sir.
Yeah. Thank you, Dr. Manjunath. Thank you, Dr. Zargar, my colleague, for giving the introduction to the insulins, how it has moved 100 years. Professor Chandalia, Professor Subhankar, Choudhury, and friends. Now we know that insulin was discovered 100 years back. Now the question is how to deliver insulin. Insulin is a protein which cannot be delivered orally because if you take orally, it gets disintegrated, proteins become split into amino acid. So the whole structure to be retained, it has to be injected parenterally. Then the problem came how to inject insulin as such, subcutaneous, intramuscular, intradermal and all. As you see, prior to 1985, insulin administration meant using a large glass syringe and a reusable needle had to be sterilized and boiled. This is not what I have heard. I have seen 1970s when I entered the medical school. I used to remember that you were getting the syringes. It has to be boiled and needle has to be boiled. Thread that needle into that syringe and draw the insulin and give it. And that is how it used to be. Even in 1985, when I went to All India Institute, they used to draw only 20 or 30 samples. I said, only why 20, 30? No, sir, we get only 20 autoclave syringes. So we are giving date after 1 month for coming and drawing blood. Those days, at least 85 plastic syringes disposable are available. That was the state of affairs 1985 in All India Institute. You can imagine how the state of affairs 1970 to 80 was. And this problem of taking a glass syringe, drawing that, injecting was a very difficult, time-consuming, inaccurate, tedious, both for the person who is with diabetes as well as nurse. I remember initially, every day the patient used to go to doctor, an LMP doctor, take injection. Morning and evening when the clinic is there. Or go to a nurse and take it. The things have changed so much. Patient found insulin therapy not only painful, very cumbersome also. And when it is boiling, you can't take it without, you should have something to take it. When you take out the syringe, it used to drop on bed many times. People used to buy so many syringes. Poor compliance to insulin regime, I said, because they were fed up taking this, boiling it. It was a big, very cumbersome process, I said. And there was incorrect dosing because they could not take 1 unit. If you take 1 ml, 2 ml, even 5 ml syringes were used, the error may be 4 to 8 units also. Then poor safety for patient with more chance of hypoglycemia. In the process, either they took more insulin or less insulin. That's why most of them were poorly controlled, not only because insulin syringes were poor, even monitoring was almost zero. We used to have Benedict solution, boil that, and then put urine, and then look 0.5%, 1%, 2%. 0.5% takes the same one. 1% increase 4 units. There's no question of glucose meters at all. So most of the patients were unhappy. And Professor Zargar has told you how the quality, quantity of life improved. If you go back 400 BC, average lifespan of a human was 20 years. It took 1,900 years. By 1900, average lifespan came up to 40. And in 100 years, 1900 to 200, what has not happened for 1900 years, in just 100 years, the lifespan increased from 40 to 80 to 83. And the contribution of insulin is no less for all these. Apart from whether antibiotics, medical care, and all, insulin played a great part. As Professor Zargar told you, lifespan was 1 to 2 years after diagnosis. Today, a type 1 diabetic can live as long as well as any non-diabetic also. Compared to that, what we have got today, insulin delivery systems are less painful, improved compliance to regime, fewer hypoglycemic uh, episodes as such, better glycemic control. We have HbA1c. It was not there 30, 40 years back. Patients are satisfied. It says, sir, it's not a problem. 3 or 4, I can take any number with a pen. Improved quality of life. So living with diabetes, they say cost saving. What they spend on insulin or medication is a very small part of it. Improved convenience with the pen. Wherever they are in the world, practice, whether they are in office, whether they are in a flight, wherever it is, they can take insulin. It is not like in the past, they can take only at home, morning and evening. No question of taking insulin in the afternoon. Ease of use for the patient and the caregiver, that's what we have seen. Now, as Professor Zargar said, evolution of insulin, the evolution of insulin delivery is also a very long journey from 1921 to 2021 today. If you see discovery of insulin, naturally with the same time, the syringes were there and commercial production of artificial insulin uh, started. First, you see that insulin syringe was 1924. First disposable glass syringe, what's called as high-pack. At least I have not seen that, which was there in 54. Then first insulin pump was seen in 60s. I saw the first pump in 1985. 85, there were 3 pumps in All India Institute. Nobody knew how to use that. When I became a DM student, I took out, went through the literature. We used the first MyFuser insulin pump. This MyFuser was the insulin pump of this size. It was costing 10,000 rupees. It was the office was in Chakala in Andheri, Bombay, and it closed promptly after 2 years because nobody was using to buy it. So much so people said, no, insulin pump is only for the museum, it is of no use. And I could use the from 85 to 87. When I left All India Institute, all 3 pumps were used. It was only for inpatient. We could not afford to send the patient with pump because he may disappear with it. I remember one of the patient type 1 could not be controlled with 400 units of insulin in continuous subcutaneous MyFuser pump. When I one day read and then started putting that into a cannula IV, for 6 months he was on intravenous insulin pump. Only one patient I have seen in my 35 years of experience, she was on IV insulin and she died at 35 years because of macrovascular complications. Then you see 1970, that introduction of first commercial insulin pump. Then you see the first insulin pen, 1980s. At least all of us have seen 1980s insulin pen. First generation insulin pens were 1990s. It was introduced. Then introduction of smart pumps, emergence of sensor augmented pump therapy in 2006, and the next generation of insulin pens. Then you see first hybrid closed loop system was involved in 2015 and it was approved also. And artificial pancreas or closed loop system was approved in 2015 and it is already available. Then FDA approved the ACE, that is Slim X2 insulin pump in 2019. Now they have tandem control like they have got insulin pump, they have got sensors, and we know all of us know about Minimet 670G with a guardian sensor where the sensor can talk to the pump and you don't have to bother fill the syringe and forget about it. The basal insulin is taken care of from 2017. Though it has not yet come to India, I'm sure in 2021 it will be coming. It's only integrating the software, that's all, nothing else. The pump is available and you have got the sensor available only to integrate the two. And thus the life of a diabetes has taken so much of change from cumbersome glass syringes to disposable glass syringes to pumps, and we have got pens, everything. So all age groups, whether a 1-year-old child to 99-year-old man, with all this technology, the delivery system has undergone huge change in the last 2 to 3 decades, as we have seen in our life itself. Look at this 1924, first specialized syringe for insulin injection was manufactured at Becton Dickinson. Today, BD is one of the leaders in the insulin syringes as such. And this is how you see the pen. As you can see are 5, 10, 20 units, and you can make 1 unit. And with this, we don't know what is the dead space. 1925, first Novo syringe was there. 1954, reusable glass and metal insulin syringes. And that is how you see these are the anecdotes. A type 1 diabetic, Elizabeth Hughes, had to take 5 cc at a time. Her syringe only had 2 ml. As you can see in this, it's only 20 units in this. So she had to take almost the much more than that 5 cc at a time. So the needle had to be left in place. Even now, a lot of people do it with the more than 40 instead of buying U40 or pen. They take that and take out the needle, keep the needle there, syringe, again refill it with another, take it. And so it was very, very cumbersome. Procedure took 20 minutes. Today with a pen, it hardly takes 5 to 10 seconds to take insulin. And her hip swelled and her whole leg went numb. These symptoms resolved only after an hour of careful walking. But she was happy to accept all this in order to be able to eat real good food. Professor Zargar already told you how this patient was taking 20 grams of carbohydrate, 10 grams of fat, 10 grams of this one. Because of malnutrition they died rather than anything. This is what is history, what you have seen. 1954, this syringe at least I have seen when I was in medical school. This is the insulin syringe that was used. First disposable glass syringes appeared high pack. Then plastic syringes came in 60s, but still though it was available in 60s, even in 70s, it was not widely used in India as such because of the cost and non-affordability and acceptability by the patient. From 61 to 80s, as you can see here, U40, U100 syringes, and you have got the pens and pumps. So the drawbacks of all these was cumbersome, difficult to transport. I remember people carrying these things in a pocket, and we used to give that pouch also. Inaccuracy in withdrawing the correct dose of insulin. Difficulty in mixing insulin. It was a big thing. I remember in 90s, as Zargar said, we used to have it for every patient, even doctors, whether to take short acting first and then long acting. And sometimes you don't take care, the insulin goes back, and then long acting also short acting becomes long acting. These are all the problems. Drawing insulin mixing was such a big thing for hours together. Used to demonstrate nurses and doctors. All those days are gone. Stigma of injection, needle poses sharpness, loses sharpness, more and more pain. We remember when the initial disposable insulin needles came, sometimes pens, they used for 1 week, some of them 1 month. I've seen one patient using it for 1 year. I was shocked. How can you use a disposable for 1 year? No, sir, I can't afford that. So this is what we have seen in 80s and 90s, and thankfully that the change has been there. And because 1985, that we found the first ever insulin pen, compact, convenient, discrete alternate to vial and syringes, short needle and incremental 1 click per unit dose. Just 1 click. I show the patient, this is the needle. Can you see? No, sir, I can't see the needle. See, it is so thin, and patient acceptance is almost 100%. Lead to a significant change in the way patients were treated and acceptance of intensive insulin therapy. I remember 70s, they used to have only lent and plate. No third insulin, no question of human insulin. So the doctor used to draw lent and plate, mix it and give 1 dose of insulin for them. Very few people took 2. There's no question of 3 doses at all. This basal bolus insulin did not exist at all. In fact, the regular insulin came first, as Zargar said, animal insulin. So somewhere in 20s, right up to 50s and 60s, where there was no premixed insulin, people used to take only 3 shots of regular insulin, no long acting. Once Lente came after 60s and all, people were very happy, and they thought taking 1 lent insulin will control. Like many people today believe that 1 dose of long acting is good enough to give me 1 dose of insulin which cover 24 hours. When people changed from 3 doses of short acting to 1 dose of long acting, it became very bad. Even when they changed premix, it was bad. They did not realize premix should be taken twice a day. So the evolution of insulin pens is from 1985 Novo pen, then you see 2001 Flex pen, then Huma pen Ergo, 2007 Pen Royal, Solostar in 2007, and Nova pen for 2006. That's what most of our is. Then Quick pen, InsuPen, Flex Touch, and Solo Star. So many of these, all these have come. But basically, it is the same technology, whether you have metal or a plastic one. Sometimes you have a problem. Like some patient takes, let us say, only one type of pen, and you have got two different insulin. Maybe regular in the morning, regular in the afternoon, premix in the night. It leads to confusion. Even today, patients say, "Doctor, sorry, I took the insulin in the night. What I should have taken in the morning? Oh God, you have taken so much of insulin." To avoid that, many times you give two, three different colored pens. Some companies have two, three different color pens, maybe red, maybe green or blue, whatever. So use red pen in the night and gray pen in the morning. This is how, though sometimes people make it say, we are using two different pens for this reason. So one company manufactures three different, or sometimes you may use two different pens from two different companies so that patient cannot get confused that I have taken morning or night. He gets confused which one to take. Some of the patient even cannot read. So that's why they write on that morning and night. Some people cannot even write anything. They'll put a sun over the morning insulin and a moon over the other one. When they take the pen, when they say it is sun, this is for morning. When they shows moon, I should take in the. So every patient evolves his own method of how to use it. If you see types of insulin pens, they call it as durable or disposable. Some people say permanent pen, and those who cannot understand what is durable pen, permanent pen, you can use it lifelong. What is disposable pen? It is temporary pen. Where do you use this? If you see the durable or permanent pen, this type of pen device combines reusable syringes insulin container with a disposable insulin cartridge. All of you know about the cartridge. Change the cartridge, you can use it lifelong. Durable pens can be reused by the patient, refilled by obtaining cartridges into to load into the devices. Whereas the disposable pen cartridge is designed with a built-in and pre-filled insulin reservoir. Once empty, device has to be discarded. Patient must use another pre-filled device. If you see patients who use long-term insulin, it is more economical to use the durable pen than disposable. Where do you use the durable pen? Where do you use the disposable pen? Patient with long-term diabetes, and they have to use the permanent pen. Ask them, because most of the companies are giving free pen. Patient with diabetes who have manual or visual impairment, they will use the permanent pen. Whereas somebody wants to use short term, maybe before surgery in the hospital or even beginning. Nowadays, I use insulin. If the HbA1c is 11 or more, I ask them to buy one disposable pen which contains both a long-acting insulin analog and a short-acting insulin analog. I tell them buy only one pen, and by the time this pen is over 350 units, I would have stopped insulin. You will be back on tablet. So most of them, 90% accept. Okay, Dr. Shah, it's only for 1 month. You are going to put me on tablet? Yes, because the HbA1c is so high. Newly detected severe hyperglycemia. A1C about 10, what the guidelines. I go even up to 11. Today I had a patient whose HbA1c was 10.9. I had put him on tablets and he was all right. Another patient came with 11. I said 1 month take insulin. He said yes. Insulin initiation. Why? If I start with one type of insulin, when they come after 1 or 2 months, I may change the insulin. So I tell them, take a disposable pen. After 2 or 3 months, when your dose is stabilized, then go back to durable pen. Hospitalization, per-operative, pre-operative, pregnancy, elderly patient where the lifespan is limited, patient with visual disturbance, dexterity problem, they can't go on turning all these. Patient undergoing surgery, as I told you, patients have difficulty in loading the cartridges, putting the needle, they make mistakes, it may leak. So these are all the examples of the pens that are available, which are durable and disposable. Most of the companies have both the pens. They have durable pen as well as disposable pen. I don't want to go into all the details about how from 1985 to 2021 various pens are there, and these are the ones which can give you as much as zero point 0.5 units. Today you will see the pen where you can deliver even half a unit. We have got very small children, 1 year old, 1.5 year old children, where we may have to give zero point 0.5 units. Some of them have gone into honeymoon phase. We don't want to stop insulin because suddenly it may go up. We may give half or 1 unit. So there are pediatrics pen where you can even alter that, and you can see these are all the very different ones. Not only that single color, metal, plastic and durable, and for children and for different color also, as you can see here, 2 3 different colors, so that this is in the night, this is in the morning, so patient can recognize, there is no problem at all. And the advantage of these pens are you can go up to very large doses. Previously it was only 36 units, then later on it became even 60 units. Now there are pen which will go beyond 70 units in the single dose also. They don't have to turn again, do it. So that's why from what you have got 36 units for maximum dose, today you have pens which are more than 70 units. So look at different manufacturers, whether it is Novo, Sanofi or Lilly, they have got different types of pens, different colors, and you can use, as I said, told you, this is the one where you have got the Flex Touch and Solo Star has 80 units for them. Quick Pen has only 30 units. Maximum units, most of them have about 300 units, and you can dial back also. This is the advantage. By mistake, they turn the pen. Oh God, I should not take it. What to do? If I press, it will best. Now you can turn back. There is no problem at all. So nowadays we have got even smart pens also, where when you give the dose, it will record how much. 180 doses of insulin it will record. Still smarter phone is when you press that much, automatically from the pen, it will go to the Wi-Fi that so much of insulin. Today we have got connected smart glucometer, we have got connected pens where the pen when you take insulin that into the EMR or to the Wi-Fi it goes. The patient blood sugar was so much automatically when it takes insulin automatically you can monitor. As you can see, continuous subcutaneous insulin infusion pumps, a very cumbersome insulin pump on 60s. Then you see wearable device, you can see how big it is, as if it's a backpack. Then auto syringe manufacturer and market, big blue brick. Then you have got biostator. I remember it was there in Chennai. People used to go and see, oh God, it is not that the pump is connected to the patient is connected to the pump. This is what we see Minimed when you see 90s. As I told, the first one I used was my fuser insulin pump, Japanese 10,000. Then when I started my, after post-DIM, I got Greasy pump, which used to cost 40,000. Today pumps are available for 5 to 8 lakhs also. And you see, this is the artificial one, 670G, where you have got Guardian sensor and we have got a pump and this sensor is talking to that. With artificial intelligence, probably one day we will have a pump where just fill it and forgetting basal bolus also it will take care, provided you enter the calories of food that you have taken. So 1963 impractical for daily use, and you will see backpack like micro and like size 400 grams pump, and restricted use complexity, batteries needed to be recharged too frequently, limited safety, and locked controller safe insulin delivery, offered very little flexibility, infusion sets as metal needles, some required use of a screwdriver per dose. I still remember where I had the first my freezer pump and used to take a screwdriver, start 1 unit per hour, increase it to 2 units, 3 units. We have used these things in 80s and all this. Now we see that it's automated. You decide what is the bolus and baler, and you say, okay, 8 a.m., 1 p.m., 8 p.m. So bolus has to be given 10, 6, 6, finished, and it will automatically give. If you don't want to press the button stop, it will be there. You want to fix it from 6 a.m. to 12 a.m. The basal insulin 1 unit per hour, then zero point 0.5 units per hour, zero point 0.1 unit to 10 units per hour, you can change it. This is what we have got compared to the pumps in 63, 74 and 76, 2021. As you can see, it is as small as a pager size pump with enhanced safety measures, long life batteries, wireless experience, as I told you, and you don't have to have any wire at all. Large screen where the displayed information is easy to read. Patient can program several different basal rates starting from zero point 0.1 to 20 units per hour and in a day to accommodate diurnal changes. Smartphones have built-in dosage calculator, I told you, to perform automatic estimation of insulin remaining active from a previous bolus and can estimate the amount of insulin that should be administered. You fix in this 670G, low is 70, high is 140 or 160. The moment the blood sugar comes 140, 130, 120, 100, pump is off. The moment blood sugar starts from 90 to 120, 130, pump is on. So 24 hours with the basal insulin, you will see the patient will not go into that. Plus artificial intelligence, it's say, now we are on pump, please be careful. Another 4 hours, your blood sugar is likely to be hypoglycemia 60 or hyperglycemia 400. And there are pumps which will give alarm. Not only pump, even the sensors also. So that way it is becoming more and more automated, artificial intelligence, machine learning. I am sure in few years it will be what is known as, what we have got is a low artificial intelligence. Next we have general artificial intelligence. I am sure in another 5 years we'll have super artificial intelligence where the pumps will think like an endocrinologist or diabetologist. You don't have to worry about that. The pump will be fed by this artificial intelligence. You fix that 90 to 140. It will never go below 90. It will never go 140 or 160. Insulin pumps today can now work in connect with continuous glucose monitoring, as I told you, the Guardian sensor. To summarize my talk, with advances in insulin development, it is of equal importance. Note, advances in insulin delivery device over the century. Zargar told you from 1920 to 2021, and delivery system are as important as insulin. No doubt we have got smart insulin, better insulin, and unlock. We have got smart syringes, smart pens, smart pump, and maybe you will have over smart pumps also. Evolution transcending from glass syringes, mass-produced disposable syringes, insulin pen devices have revolutionized the patient side care of diabetes. I see in my practice almost 99% use the pens. Hardly anybody takes syringes these days because every company, most of them are giving free pens, and the syringe and the insulin is probably something that it is outdated. Today, most of them pen, at least majority of the patient, it is affordable, and many reimbursable category are also reimbursing the pen as well as cartridge. I hope in future they will reimburse the pump also. Diabetes management with insulin has been made simple, patient friendly, and safe through the advent of pen devices. So acceptance of insulin is almost 99% compared to what it was hardly 50 or 30% 20, 30, 40 years back. Insulin pumps have evolved rapidly since their introduction 40 years ago in order to become smaller, more precise, and more reliable, evolving towards autonomous, integrated, instantaneous fluid, glucose sensing, I told you, the Guardian sensor, and insulin delivery system, as if it's an artificial pancreas closing the loop. Thus, with a better insulin devices, life of a diabetic is much more comfortable what it used to be 40, 50 years back, what we have seen compared to today, which is very easy, simple. Thank you for your understanding and your patient listening. If there are any questions, please put it in the chat box. At the end, all of us will try to answer the question. Thank you.
Thank you so much, Prasanna sir, for giving that beautiful description about the journey of insulin delivery devices. And you have told us right from the day when it used to take 20 minutes to inject one injection of insulin to the present day, in which just it takes a few seconds, and how it has become more and more patient friendly, and the relentless innovations that have taken place has made it more patient friendly. Thank you so much for that. Dr. Subhankar Choudhury sir has joined in for today's meeting. Sir, welcome to the meeting, and thank you so much for joining. It is time now for us to move to the next session, and we are privileged to have Dr. H.B. Chandalia sir, who is a very senior diabetologist of the country. And today we are going to look into the innovation of insulin, look into the milestones of insulin through his lens. That's because he has close to probably, I can say, 6 decades of experience in managing patients with diabetes and using insulin therapy. Sir, it is a pleasure for us to have you in today's presentation. Sir, do you want me to present the slides, or would you like to take control?
You present the slides. I present the slides. Only change it fast when I tell you. Yeah.
Okay. Yes, sir.
Sure.
So I'm just going to take over as the president.
Yes. So my dear faculty colleagues, and of course, ladies and gentlemen, doctors who are participating in this. Now, next slide we can go to. Yeah. What I'm going to do, and I've been asked to do, is really show that these wonderful insulins that came along and delivery devices which came, how it changed the practice pattern in my practice of 55 years. So I'll take my practice period as when I finished my MD, and that was 1965. And for a year or so, I still stayed in India and studied college. I went on teaching. There, of course, we had a diabetes clinic already at that time, which was wonderful. See, the diabetic clinic, it is one of the earliest diabetes clinics in the country. Also, sometimes people in South always say everything that happens even tomorrow is before 10 years, So you see, that is different. But I think it was one of the very early clinics established by Dr. Sathe, who was a very illustrious physician and later on became Vice Chancellor of University of Mumbai. So I saw some good practice of diabetes there, and I developed intense interest in endocrinology and diabetes. And on 67 to 74 years in US, fellow, and then I was teaching there as assistant professor. So what I saw and what I saw the practice is something very interesting. So here we are with glass syringes and insulin, which was a mixture. We saw that insulin was a mixture of not only animal origin, but in India, what was marketed was beef and pork mixture. So you never know what was the proportion of beef or porcine insulin in that particular vial. See, and of course, it was very well known at that time that beef insulin is far more antigenic and can give you less consistent response than porcine insulin. Because porcine insulin and human insulin are very close to each other. If you remove the last alanine and replace with threonine in the B chain, then it is human insulin. So it somehow worked much better. So this was what I used in India. In US, when I went, I think the porcine insulin was mostly used. It was freely available there. It was always U100 insulin. The syringes being used at that time were already all disposable. There were not pens yet because it was 1967. Otherwise, things are very smooth in US. You see, the type 1 diabetics, of course, put on all kind of insulin regimes. There were no pumps also at that time. Monitoring was just coming up. The meters were just entering the market, but monitoring was not very frequent, even in US. The blood glucose monitoring in 67, it picked up a little later on. Now, this is how it went. I participated there in a university in a study called UGDP study. It is a very interesting study, celebrated study in a way, but the study probably runs into 30, 40 pages of report, but the critique of this study went into volumes because people started finding flaws with the study. But what it proved was something very interesting. So I came back with that kind of thing, fed in my brain that, you see, the study had an oral agent arm, which was really tall butamide, was the only sulfonylurea freely used in USA, so it was there, and there was an insulin arm. The comparison showed that insulin is much better. So I came with the concept that insulin should be used more frequently than what we do in India. So 71, I was back to India. I joined my medical college as assistant professor, and of course, there was no chair of diabetes or endocrinology. So everybody was professor of medicine. Then you could do your specialization the way you want. So here again, I'm back with glass syringes, occasional use of disposable syringes, you see, and needles which used to be 26 gauge. The needles, most of the time I saw was 26 gauge, and they would be about 12 millimeter long. Most of the time, about 12 millimeter, a little more than a centimeter long needles, and 26 gauge. You know that needles at present are 31 gauge, and all needles most of the time are 4 millimeter. It's very rarely that you use up to 6 millimeter, because now we know that skin of all human beings, the thickness is 4 millimeter. It includes people like politicians who we call thick skin. The skin really not thick. You see, it is same as our skin. So I think, so now what you have is 4 millimeter needles most of the time your patients. And it is very scientific because it delivers the insulin in the right place. So it all changed, you see, slowly over the period, as you saw my previous colleagues describing for you. And then, of course, the efficacy and safety was there, but hypoglycemia is very frequent. what we had available, of course, was plain insulin. And by this time, NPH and little later Lente came in. Lente insulin was used until about a decade or decade and a half ago. But it always had a little more variability of response because excess zinc will sometimes give you a little different amount of plain versus other insulin. It's a mixture. And NPH insulin, of course, we would mix with plain and inject. So the best regime in a type 1 diabetic is the NPH plain mixture in the morning, sometimes a plain in the afternoon, and NPH plain at night. This was the best we could do because we understood that type 1 is difficult to treat with one shot or two shots or any kind of fixed mixtures. You practice that. Type 2 diabetics, we injected insulin very rarely unless the patient was very poorly controlled. The real indication, which to my mind today also is the indication, and that is one you must always consider, is unintentional weight loss and a catabolic state in your patient. And you are waiting with oral agents. Now you have huge armamentarium of oral agents available, but for you to wait until the patient starts losing weight is really a very bad practice of medicine. So I think that is absolute indication to institute insulin therapy, even in a type 2 patient. Type 1 patient, there is absolutely no doubt. How was insulin accepted at that time? Let me tell you that it was accepted with difficulty. Children, of course, we had to explain for about an hour that please don't stop insulin. Please don't do that. The child will go back into ketoacidosis like the child presented with such a serious illness. Same illness will develop in about 2 or 3 days' time, or shorter than that. Please don't do that. Even so, I remember vividly a young girl, very sprightly, girl whom we treated for DKA and brought her out. You see, completely, beautifully controlled on 3 shots of insulin. And the parents took her home. And after about a week, I get a phone call at night, dead of night, 2 a.m. that she's not well. Will you kindly come and see? So I got up, I went to their home, and I saw there. What I saw was a dead child. And I was very disturbed in my mind. I said, what did you do to this child? And they said that, we did not like this insulin lifelong, so we just stopped. This was a murder. I refused to certify. I got out of the house and I said, please, I cannot do anything. I'm just walking out. So this could happen. These are very reasonably well-to-do people. But the concept was incurable disease. We don't want a child. Amazing. See, so this sort of very traumatic experiences are possible. This did not happen after that, fortunately, to anyone, but this was a very peculiar family. I think there were plenty of daughters. I went to the history of that, why they hated, why they would not let this girl live. And I found that there are 3-4 girls in a row, and they were determined to kill her. See, so this could happen. Fortunately, this does not happen anymore now. But remember, the parallel systems of medicine can come in your way. Even now create a lot of difficulties. It's amazing that in this modern scientific period also, somehow or other, politically we continue to support different systems which are not developed beyond what they were thousands of years ago. So I think it is something which all doctors really should slowly, lobby and really stop these sort of systems causing problem in the delivery of good modern medicine, which the whole world is moving towards that, except probably China. But we don't want to emulate China now in any way. You see, now, of course, I must tell you that in India, this dirty insulin, which was, can we have the next slide, if you, Dr.
Yes,
Manjunath?
Yes, sir, yes.
Next slide. We can go through the slides quickly, but I'll tell you the story side by side. Frankly, I don't see my slides. Can you?
Yeah, 1 second. They're just
Yeah,
coming
that's
up.
fine. Yeah. So I think see here you have different kind of insulin.
No.
This is almost pancreatic extract, and then you have porcine insulin. Then you have a long-acting glargine, and now you have state-of-art insulins like you see degludec and the glargine 300, which are the best basal. And the concept of basal bolus came later, much later. At that time, the concept was that multiple doses, 3 times a day of regular insulin. So they develop NPH, Hagedorn developed that, Alas Moller developed that thereafter. And then they were used in order to minimize the number of injections because injections were painful. Now things have changed completely. Now they are no more painful. They are, I would say, they are virtually painless. In fact, some very small infants, like even 2-year-old, we recently started treating, and I have done this some time ago, quite a few infants even. You see, and we have told the parents that you can inject in sleep, and the child would hardly wake up. And this is the fact. They don't wake up. They may just turn around and go to sleep. So I think they are virtually painless. So now again, the whole thing had turned over. Earlier on, the search was for long-acting insulin, so that you can minimize frequency of injections. Now it's other way around. The injections are so easy and so comfortable that you like to deliver insulin in the most physiological way, which the modern insulins are giving you. So again, we are going to multiple doses. If you want to really emulate physiology, it has to be multiple doses. You see, there is no way you can really mimic normal physiology by any kind of mixtures or predetermined mixtures. So you can see how the wheel has turned completely, beginning with 3-4 regular insulin. So I remember a very interesting paper by Jocelyn, you see, long ago, what was about 45 years ago. You see, Jocelyn was pioneering clinician at that time, and Priscilla White was another one in Boston at the Jocelyn Clinic in New England Deaconess Hospital. And they treated children and pregnant women. She treated 2,000 pregnant women successfully for delivery, you see. So those were the days. So multiple doses of plain were being given, you see. And versus that, when NPH came, Dr. Justin offered whether we'd like to combine. And now you want to take NPH twice a day with little plain, or you want to continue with multiple doses. So some people opted for multiple doses, some for the long-acting insulin and less doses. And there was a beautiful paper, very simple one, showing that those who had multiple doses, continued regular insulin, came out much better after 10, 15 years. So you see, it starts from there, that really mimicking physiology different. But now when we are prolonging action, it's entirely different. That is for basal purposes. So we understood the concept of basal and bolus now, and we have basal, which covers beautifully, is a peak-less insulin, less likely to produce hypoglycemia, because any insulin will produce hypo, but the speed with which the glucose is lower is not so intense that it will ever produce very severely disturbing hypoglycemia. So you combine that with plain and your regular or short or ultra short acting. So you see how the whole therapy has changed over these years, and I have witnessed all this for 55 years. Starting from now, looking back, we say from a very primitive insulin therapy with mixtures to some elite insulins which are now. But let me tell you, still the ideal insulin is a little bit far, and I'm sure Novo is again going further, and I'm sure some other companies will go as well, because we have very fast acting insulin like fast aspart now. But when the normal insulin secretion starts in human beings, when they think of food, when they smell food, the insulin secretion starts. See, so I think you need faster than fastest insulin. So some of this can be administered by pumps. See, and now Fias has been also used in pumps as well. There are good papers that it is pump-friendly insulin as well. So I think the type of insulin we use, can we go on slides, because I talked about this, so we can switch to next slide quickly. Yes. The older insulins produce lipoatrophy quite badly. Many of you have not faced this problem of lipoatrophy, but we have faced. And my 2 or 3 colleagues here, they have all probably seen lipoatrophy. They use the dirty insulin, which had 8% impurities. A lot of it was pro-insulin mixed with it, and a lot of it was some other beef and porcine proteins in it. See? And that produced lipoatrophy a lot, and allergy, local allergy was very well known. You see redness at the time, itching at the site of injection. Next slide. And this is a picture of a patient of mine at that time, young girl, you see type 1 diabetic, and injecting in arms, see how ugly her arms became. The same girl, little later, monocomponent insulins came, we put her on that. Then, of course, the human insulin came, we put her on that. Then the analogs came, so I had taken her through all this journey. This girl has witnessed all this. Now she is a very grown up, close to menopause lady. See, so I think, and later on we have to inject here and slowly fill up this lipoatropic patch. It was a very difficult exercise. Now what you face is only lipohypertrophy. If your patients go on injecting in the same place and don't change the site regularly, then you get lipohypertrophy, which is a basic characteristic of insulin because it stimulates adipose tissue, you see, proliferation. So it is going to produce lipohypertrophy if you keep on exposing a given site to that. Next slide. See? So I think, so all the develops here. Now what really changed picture as far as insulin is concerned, the two monumental studies are UKPDS and DCCT studies. And I have seen when these studies were presented in the meetings abroad, I was in the audience. When my colleagues must have been in the audience. DCCT when they were presented, UKPDS were presented in Europe, I forget the town. You see, and we listen at 10,000 to 20,000 people were listening to these studies at that time. You see, and then follow-up of DCCT has given us concept of glucose memory and all that. And of course, these three studies, which are often quoted as a trio always, it's like Brahma, Vishnu, Mahesh, they all together go. Advanced Accord and VADT. Whole idea was to give very intensive treatment, and they taught us something different. They taught us that you must control diabetes very well in the initial phase of type 2 diabetes. But once they have, and that time it is feasible to do and you must do it. But later on, with severe complications, rapid lowering of glucose and intensive lowering of glucose can be detrimental. So we learned a lot from this study. And we continue the follow-up of DCCT UKPDS, the follow-up of 10 years, or now more than 10 years in emerging. And it's showing difference between the intensive arm and the standard arm. So what they taught us is the glycemic control is required. Because many people, especially cardiologists, always projected early on when you were practicing diabetes, that you see hyperglycemia is not a very serious cardiovascular risk factor. I've seen the Friedberg's cardiology, which was 2,000 pages at that time, mono-authored cardiology book, you see, and he mentioned that the main risk factors is blood pressure and LDL cholesterol, and hyperglycemia is not a very important risk factor. This all changed. It all changed. We now know with very good evidence that hyperglycemia is a very important risk factor as well. So there will various great skepticism why you treat diabetes, you know, and sometimes somebody will make headlines in the newspaper that why treat diabetes, you know. See, so this sort of things were emerging. So we had to go through all these exercises to see. So these studies taught us a lot. Next slide. See, yeah, and of course you see. Now, what were the most known facts for doctors? You know, of course, we always talked about hypoglycemia when you prescribe insulin. That was, of course, you know, if you don't do that, you're in negligence, in medical negligence. But today also, I hope none of you let your patient go after initiating insulin without telling about hypoglycemia. We tell about that, and my educators, now we have educators available. So from 71, I started practice in Mumbai. I was honorary professor, so allowed to practice. And I started hiring dietitians and training them a little more into diabetes, insulin, etc., and made them diabetes educators. Subsequently, of course, we started regular educators courses. I started a course in the university here in Mumbai, 6 months course, really properly structured, and we train a lot of superb educators who do a great job and teach our patients now. And believe me, at that time, we had to sit down and teach a patient how to take insulin, how to take care of syringe, needles, change the sites, all that was being taught by us. But you see, this was considered still very important. You see, changing a patient on insulin therapy, you see, type 2 most of the time will keep on trying the drug. Oral drugs available was tolbutamide and later on chlorpropamide. Chlorpropamide was a very long-acting sulfonylurea, very potent. Sometimes we control some very difficult type 2 diabetics, but it produced hypoglycemia. Fortunately, we as endocrinology, diabetology knew how to use it. But some general physicians will give a good dose of chlorpropamide and cause not only bad hypoglycemia, but hypoglycemia which lasts for 3 to 4 days. 3 to 4 days. You see, that's a very long-acting drug. And we have seen disasters with that, and people did not know how to use that oral drug. So this was far beyond even insulin hypoglycemia. At that point, sometimes it was thought in Jocelyn Clinic, I have heard the teaching was there, that when you start a patient on insulin, first in the hospital, you start in the hospital, titrate the dose, and you show them what is hypoglycemia by injecting extra dose one day, so that they understand it. You see, Now we don't think of doing that, you see. As a matter of fact, now we use insulin also in a way and type of insulin and delivery devices and all, we use insulin without causing hypoglycemia. So that is the main barrier to use of insulin. And what I have to talk about is how we use it without producing hypoglycemia. And I think some of the sessions we were doing the day before yesterday, we were talking about how you can use insulin without producing much hypoglycemia or very minimum hypoglycemia and achieve very good control. And of course, oral agents have developed side by side, and some of them really have come in a big way. They produce a sensitizing effect. So the whole thing has changed. You sensitize a type 2 diabetic always, and with that you administer insulin, fractionated doses, and very carefully, modern kind of insulins, you can control very well without hypoglycemia. And last of all, delivery with the pump. See, I taught a workshop on pump therapy. It was the first workshop in our country in Delhi with Dr. M.M.S. Ahuja, myself, and two professors from US and one from Germany. And we taught pump for 3 days. I was already using insulin pumps. This is around 90s. I was using pumps already, and I presented my cases as well. Same my fuser pump that Prasanna said. I still have the sample of that and several old pumps. We can put it in some museum later on. You see. So anyway, so we use those pumps. And now I have something like 60 or 65 patients. You see, many of them have already migrated abroad, youngsters, you see, and they are on pump for 25 to 30 years. I have patients who are on pump for 30 years. 30 years, beautifully controlled. I had type 1 diabetics who have 40 years of type 1 diabetic. They're still running big company, industrialists, not a speck of change in a retina, no microalbuminuria, controlling beautifully with pump. See, so this is achievable. This is achievable. See, so with the current tools at our command, this is achievable. But it needs good knowledge. It needs good application of knowledge, and it needs support from educators, support from your colleagues. All that. So next slide. Can we go there? Can we go further, please? Next slide. You see,
Yes,
patient education. You see, most of the time we did. Then we had the dietitian who we trained, we did, and now we have educators who do wonderful teaching of our patients. They spend enough time. In fact, the first time we see a patient in our clinic, roughly we tell the patient that keep 2.5 to 3 hours free, then only take our appointment. Because up to 2 hours they are in the clinic. They have to be. When we start with them, we may not able to start for half an hour. So 3 hours they may take easily. So the education part is so different. But it was being done right from the beginning. Diabetology is one specialty where the physicians have been very much interested in educating patients. This is one specialty where education is a big way, and it's a chronic disease where education is most important, and continuity of care is the next thing. I must say that what we have not achieved in India really is continuity of care. We have very smart endocrinologists and diabetologists, you see, and we have good number also. We are now churning out in the south. In fact, every doctor is a diabetologist in Chennai, you see. So we have plenty of them, you see, and some of them do 3-month certificate course. Of course, you know that you really can't become a specialist in 3 months. Some of the correspondence courses, but even then they gain some knowledge, you see. But continuity of care and records keeping is not developed. Let me tell you what is the real deficiency in the country in practical application, So that I think is lacking, which is very, very important. Next slide. I think we go fast. I can take more time. You see, the indications, of course, the DKA and the child was always treated. Pregnant women we treated at time with dirty insulin. Not very great results. Subsequently, we delivered, I think, more than about 12 women are delivered with pumps, type 1 diabetics later on very successfully. Some of them 2 pregnancies in some of them. You see, oral drugs, there were very few there. I must tell you that. I was a proponent of insulin. I returned from USA with that halo of UGDP study, one of the participants. And my professor, very gentle person and very kind, Dr. Talwalkar, he kindly told me, Dr. Chandalia, you are a proponent of insulin, but don't you think with insulin you give this tolbutamide also, you get very good result? I started thinking that, person requiring insulin, how is going to be in pancreas be stimulated? And later on, I learned or little bit I have learned in USA also, that extra pancreatic effect of sulfonylureas are profound. You see, and actually a combination of insulin and sulfonylurea was the combination we gave in a difficult type 2 who was not controlled. And I continue to do that, but I use something like glycoside 20 milligram 3 times a day, not the long acting one. To use sulfonylurea with insulin is dangerous most of the time. But glycoside 20 milligram TDS, if you people are having difficulty with a type 2 patient, give multiple doses of insulin with 20 milligram glycoside 3 times a day, you will get result on day 4, which the patient has never seen that result. You're going to see it. Try it out. Okay. So this is how it use oral agents, and we continue to use now the different ones, the DPP4 inhibitor, SGLT2 inhibitor to sensitize them, and of course the pioglitazone, which had its own history of coming and getting condemned and again returning back in some way. You see, and of course underused now, according to me, it should be a little more used than now, being used pioglitazone. So because the newer ones have really entered. You see, so next slide. So I think we'll go very quickly. This all has been seen. You see, let me tell you that use of pen started little bit in India ahead of USA. In India ahead of USA. I'm talking of urban India. Pardon me, because I have no contact with rural India. After all, you can't do everything in this life. So, try to do, but urban India, my patients are using pens more often. I had patients in USA living there and coming and seeing me regularly when they visited India. I had patients in UK. I always had a lot of patients in different countries. So they were still using syringes. They used to come to India. I said, why don't you take up the pen? Say, they are there in USA, but we are not using them at the moment, You see, so pen use was picked up very well in India and it is taken very well, you see, and I think it was quite fast in India, which it can. The good insulins which are being marketed by Novo Nordisk, you see, earlier they marketed with a company, you see, a small company. I think Sarabhai is the ones which they had tied up with them. They were marketing, but the supply was intermittent. So what problem occurred is the Sarabhai people was brought one Mr. Christensen. Oh, there are too many Christensens in Norway, but this was a Christensen whose family owned the Nordisk company, which later on merged with Novo. I can tell you history to Novo people, their own history, You see, so I think he was the owner of Novo Nordisk, part owner. So he became an Indophile. So he'll come regularly to India. Started loving India. But when he came to see me, I flared up. If you want to market your insulin, why don't you market properly? I need them badly. My patients have allergy. My patients, have lipoatrophy. Why don't you market? Many of them can afford. They thought that India is an extremely poor country. What are we going to do by entering India? When they saw my passionate appeal that you must market this insulin, I think he caught the lesson. He was one of very high in the hierarchy. So he probably set the tone. In this country, we must go. The doctors definitely want us. So we should do that. And of course, you know where Novo is now. Next slide. So I think this sort of very interesting thing happened and how we these needles changing. Next slide. You have seen all that. My colleagues have given you. So I'll not go for that. For dosage, hypoglycemia, I see prescription has changed. Now we use insulin, which has less glycemic variability. You see, we have low dose requirement, less weight gain. If you use enough patient, less weight gain, all that is occurring. So we are using insulin very efficiently. You see, now what I'm looking for then, you can say these are some of the best products what you have. Now what I'm looking for now is one insulin, which is, it's like pegylated Lispro, which are shown, which will go in the liver, because see, what is not physiological now remaining is really we are injecting insulin in the systemic circulation and not in the portal. You see, so I'm looking for that. You see, when you use a pump also, frankly, you are not still close to physiology, except pumps were implanted intraperitoneally, but because of infections and all, there are very good papers early on pumping intraperitoneally, and then they had to go back because it could not be implanted for more than 3 months, 6 months, bad infections. So anyway, so I think what you have really is very, very, very sharp tools, very smart tools we have, you see, and I think we are able to help our patients much better. The capability to help them, we learn to use those tools very well, and let us it's a blessing that we have these tools at our command and we can help the people. Any more slides? Next slide quickly. I'll just pass on very quickly because I think this all has been said. So next slide. I don't think we should lose time except saying, see, my talk was supposed to allow me to give some flight of imagination and some personal touches. So pardon me. So I'm doing that purposely because this is what my topic was. And now, of course, we will go for very good kind of insulin regime, which we keep discussing. You hear many of us describing those regimes for you in many CMEs. So I won't go into that today. Next time, there's no time for that. See, so I think the importance. So now, of course, the diabetes lifespan is increasing quite a bit. I think and I think some of them are almost reaching 85, 90. I do have patients type 2 who are now 85, 90, and their disease is 30, 40 years. I'm type 2 also, that old, So I have a group of that also. Next slide. So I think things are changing. Things are changing. Very good. And this is that, I think, talking about that Solomon person in yellow, Rosalie Yellow was a friend of my professor. So we met very often in USA with our training. And she got a Nobel. Person was no more, so the Nobel was given to Rosalind. And she visited India and she had a meal with us at our home, because my old connection with them. So somewhere down, I saw some of the main researchers who really, made insulin measuring possible. And then the concept of insulin resistance came because you could measure insulin in patients. And one of our papers from US was a huge data in 1968, huge data on insulin resistance, almost parallel with Gerald Reevan's insulin resistant description. So this is interesting. I've seen all these concepts developing in front of me. From deficiency disease to resistance and all that. So anyway, here you have Rosalind and Gerald Reevan. Yeah, the insulin resistant described by Gerald Reevan. And of course his syndrome, Reevan syndrome, we started learning. See, next slide. So I think obesity and diabetes, insulin resistance was shown by Gerald Reevan, but obesity, the hyperinsulinemia, one of the earliest paper by my professor, is there in the literature, and high level of insulin in type 2 diabetics is again our paper, which again, data similar to Gerald Reevan and almost simultaneously with that. Jocelyn, great clinician, and of course, in the longevity, you see here how much longevity has increased at that time during his period with the insulin use. So it was really wonderful to see those children living for more than about 2 years was the lifespan of type 1 diabetes. With complete starvation, they could maintain them. Otherwise, they would die. So complete starvation, they would at least maintain for 6 months or a year. So I think that's a very fascinating story. Yesterday, I did about 40 minutes of story of insulin, which in the link is there. Maybe we can pass on to Novo, and go into that history, which again beautifully presented by Dr. Zargar and Dr. Prasanna. So I think thank you very much for listening. I think we are short of time because all of us have overshot by 5 minutes, and end result is on Subhankar. Subhankar is it. So thank you very much.
Thank you so much, Professor Dr. H.P. Chandalia, sir, for that really nice presentation. We could see the history walk through right from the days you started practicing and right from the days you returned from the United States. What was thought about insulin, what were the challenges that you had in terms of using insulin, how you used to educate the patients, what sort of clinical data was discussed to the present day. It was a really nice presentation. Thank you so much for walking through the journey through your learn, sir. Now, moving on to the next important session for today. It is my pleasure to introduce Professor Dr. Subhankar Choudhury, sir, who is very well known in the country and also outside. Professor Subhankar Choudhury, sir, is the professor and head Department of Endocrinology at IPGME&R and SSKM Hospital, Kolkata, and he is going to talk on a very important topic. The very important topic is we have seen the 100 years of innovation with insulins and insulin delivery devices, but has there been a befitting tribute to these 100 years of innovation? And what can be done? what the doctors and patients across the country and around the world can do more so that a good adoption of insulin therapy is there and the clinical inertia for insulin therapy can be broken. Sir, thank you so much for joining here with us today to talk about this very important topic. Over to you, sir, for the next presentation.
Right. Do I share my slides?
Yes, sir.
Will you provide me? Yeah.
Yes, sir.
So capture. Yeah. I find I have to quit and reopen. Is that okay? Or would you like to share my slides?
I can share, sir. Just give me a moment. I'll share the slides.
Okay. Right. So it's always inspiring to learn from senior people and people like Professor Chandalia, and have great clinicians like Professor Zargar, Professor Prasanna Kumar. And at the same time, we also have seen so much of advances taking both in the development of insulins and delivery devices. But as was being mentioned, still possibly the usage of insulin is far less than would be optimally desirable. So we'll try and look at this discordance and try and see what best we can do about it. And in the same vein as Professor Chandalia spoke, I still do remember the earlier days in my when I joined service, and we had a clinic for type 1 diabetics, and they were provided insulin free from the hospital, and they had to come with their monitoring reports results, and those monitoring were urine glucose tests. And I do remember the poor children, they were waiting outside the clinic room, making up the urine glucose results so that they get their insulin free, and they were doing this just outside the clinics. So I think we have come a significant way beyond that. Can we go on to the next slide? So we all yes, so we all know, we see these numbers, 77 million people with diabetes in our country, but that was 2019 IDF Atlas. So now it's at least 80 million plus. And today we were discussing the ICMR INDIAB study. They have completed the essential phase of that study, and still we find overall about for one person diagnosed with diabetes, there is at least one more undiagnosed. But there are states like Kerala, for example, where for one person diagnosed, there is only 0.3% person who is undiagnosed. So there are some states where the screening has been very good. There's been states like Goa also. And then, of course, we do know that it leads to complications and leads to higher mortality, and eventually leads to a large expenditure related to diabetes. And in our country, most of that is related to out-of-pocket expenditure by the patients themselves. And we also do understand that we have an earlier onset of the disease, we have a higher insulin resistance, we have greater insulin secretory defect. So though it's diabetes all across, possibly we are dealing with somewhat more difficult types of diabetes than elsewhere. Next one. Next slide, please. And in terms of the degree of control, I think I don't need to carry code to Newcastle. Across different studies, the HbA1c achieved has been around, I mean, good HbA1c, let's say, of less than 7% is there in only about 20-25%. And once again, if I go back to the ICMR India study that we saw the results of today, possibly about a third, I think, had A1Cs less than 7%. That is a good news. But still, we do have at least 60% or above having not optimum glucose control. And that next slide, please. And that despite the availability of so many agents to treat diabetes, oral, injectable, and then of course so many different types of insulin, and we have the human insulins, we have the analog insulins, and so on and so forth. Despite that, we do have significant numbers still not achieving control. And we also do understand very well that insulin would offer the guarantee of lowering down the A1C from any level whatsoever. Others would have their own ceiling effects. For example, the DPP4 inhibitors may be around 0.5, 0.6, maybe 0.8%, but for insulins, you can go any amount of decrease the A1Cs by any amount. Next slide, please. And then we've already discussed, we have heard excellent talks about the different insulins that have come across, become available to us. Next one. And along with the different, can we have the next slide, please? Tab it. Yeah, and these have, can we go back? And these have brought with them various advantages, including very importantly, I would point out lower risk of hypoglycemia, less variability, and lower nocturnal hypoglycemia. So these are the major advances, because whatever insulin you use, the A1C lowering ability remains the same. It's not, they still act on the insulin receptor, but the pharmacokinetics are different, so that the risks of hypoglycemia, risks of the unpredictability, day-to-day variability, dose-to-dose variability become less. Next one, please. So we do have a lot of good insulins in our hand, and we also have data before us. For example, if you start from one oral agent, if I add a second agent and look at the A1C, you can very confidently hope in most instances, if you've selected your patient correctly, the A1C will drop significantly. So the blue bar is the pre and the gray bar is the post initiation of a new oral anti-diabetic agent. When you go from 2 agents to 3 agent, this drop in A1C is less. And then if you go from 3 oral agents to 4 oral agents, often we find actually, contrary to our expectation, the A1C may not drop at all. The A1C may actually increase over time. However, we all know that we do have the powerful insulin standing by, which will definitely, surely bring about a fall in A1C, but we often tend to ignore, we tend to go with our inertia and go on prescribing one after the other oral agents. Of course, if we, on the right side of this of the slide, if we do see that the usage of insulin does increase with increasing duration of diabetes. For in my clinical practice, whoever has got type 2 diabetes more than 10 years, I would be a little bit surprised if they are not already on insulin. Though I would also in the same breath admit that there is a lot of heterogeneity. There would be people who do quite well on oral agents, even for 20, 25, 30 years. But by and large, beyond 10 years, a significant proportion should ideally be put on insulin. Next one, please. And then, of course, we do understand why. And the barriers, let us also remember and let us also recognize, identify, and try and overcome the barriers amongst physicians as well. So the black bars are barriers expressed by the patients, and the gray bars are the barriers expressed by physicians, the treating physicians. And if you see, these barriers that we see, the fears that we see, are higher with the physicians. The fear of hypoglycemia, the fear of injection, the fear of weight gain, and the fear of tests. They are all in us and less in our patients. So we need to understand better, appreciate better, and therefore then we'll be able to deliver the best care for our patients. Of course, one of the major issues, can we go to the next slide? Next one, yeah. And if I look at the different reasons which delays the initiation of insulin, one's of course therapeutic inertia, because the patient doesn't complain much. The symptoms are not, because most patients with the A1C of about 7.5, 8, 8.5 will not have much symptoms. So the patient will not be bothering us that I am disturbed. So we need to pick up on the basis of reports, and we also need to educate our patients at the very beginning as to what are the goals of treatment, why we're treating, not just alleviation of symptoms, but essentially prevention of complications and hopefully also improvement or decreasing mortality. So one is chalta hai chalne do, patient is not complaining, let us just repeat all or something like that. And then of course there will be an element of lack of training, but I think the biggest hurdle is lack of time and availability of team, because advising another oral agent doesn't take more than 30 seconds, but advising insulin requires time because you need to educate how to inject, how to detect hypoglycemia, how often to test, and so on. And that together with another point which is not come across is the fear of losing a patient. Realistically, if you advise, and I think Dr. Prasanna Kumar also referred to that if you advise insulin, then the patient will go shopping to another physician and see if he or she would treat without insulin. And that's partly because of the social stigma, psychological resistance to the use of insulin. So patients would not like to start on insulin. And then, of course, cost effectiveness and tools to monitor and awareness. So all of this, I think, need, most importantly, adequate education, understanding of the process of diabetes, and not just amongst the patients and not just amongst physicians, but also we have to sort of allow the patients also imbibe as to why we are doing a certain thing, advising this insulin. And of course, we have already understood that the process of injection has become so much more easier. And I fully agree with Professor Chandalia that it's practically painless. Next slide, please. And then we have seen this slide so many times, breaking therapeutic inertia for timely insulin initiation. I think we can go on to the next slide. Next one. So about the practical solutions. So we've identified four major issues. One is the fear of injections, and as we've already heard, the process is practically painless, and I think the best, practically the most effective way is to inject demonstration of the injection by yourself or by your health or your diabetes educator when the patient is there in the clinic. And many a time I have said, especially I've seen with children, they would not agree to take an injection, take a shot, and then I would say, let me give you a shot, a dummy shot. And then they would just close their eyes, clench their fists, and then I would have injected and taken off the needle, and still they would be clenching their teeth. And then I would say, so what happened? I said, then they would say, so when will you inject? You never injected. I said, it has already been done. So if you demonstrate that it actually doesn't cause pain, I think it will be so much easier for patients to accept that. And then this is a real point that the finger stick glucose tests, they pain much more. Though also those lancets also become better, smarter, but still they pain much more than injecting the fine insulin needles. And adherence and complexity, we we do understand we have the better devices which take away some of this complexity, but we also need to be aware the number of injections that quite often are required is may interfere with the lifestyle of the individual. But if we can make them understand, I think they can build that within their own lifestyle, and so that also needs to be worked through. The next slide. Weight gain, I think we have insulins which are associated with less weight gain, but of course we need to try and address that with better lifestyle modification. And also we have the other agents, the SGLT2 inhibitor, the GLP-1 receptor analogs, which when used with insulin will counter much of the weight gain associated with insulin. And then of course, as I've mentioned, one of the major concerns in the physician's mind is hypoglycemia, because the hypoglycemia is something that brings in more fear than hyperglycemia, because the hyperglycemia will lead to complications, will lead to death, but that will be years over. But if your patient gets hypoglycemic in the middle of the night, then the doctor immediately gets the blame. Whereas even if the patients have hyperglycemia over months and years, they won't get the blame. So hypoglycemia, definitely, we do now have the analog insulins, which are smarter, which are associated with less serious hypoglycemia, associated with less nocturnal hypoglycemia. And of course, this has to be given along with proper diet advice, exercise advice, and so on, overall education and counseling. Next slide. So overall, I would suggest that still there is a lot of improvement that we need to see around us in terms of better achievement of glucose control. But of course, we also do understand that it's not just about glucose control, it's about overall control, including blood pressure and lipids and so on. And in terms of glucose control, we do understand that one of the ways that we could improve the relatively poor, I would say, overall A1C control across the country would be to accept and get our patients on insulin earlier, and also titrate the doses proper, because starting itself is not the end. This is only a start. You also need to intensify the insulin regimen in order to get a proper control. And if we do that, I'm sure in future days, future years and months, we will be seeing a drop in the level of complications that we so long are seeing in our patients. So with this, I would like to end the next slide and thank all of you for sparing your time. And if we have questions, we can of course discuss.
Thank you so much, Subhankar Choudhury sir, for giving that wonderful presentation about how insulins can be adopted better and in a bigger way for the better management of patients with diabetes. And now it is the time for panel discussion. And since we are running short of time, I'll take only 4 questions and pose it to 4 of the speakers whom we have today. Let me begin with Professor Dr. Zargar sir. Sir, there's a question by Dr. Sundaram Annamalai that he has commented that insulin is co-secreted with amylin, which is also known to have beneficial effects on the glycemic control. But why is it that the innovation of over 100 years, insulin has taken so much of a space, but not for amylin, and what can be done? Any thoughts from your side, sir?
Firstly, you must understand amylin also was used in between. But, if you look at the biology of this whole process, whether you have a patient with type 1 diabetes or type 2 diabetes mellitus, intrinsic problem before the onset of dysglycemia is insulin deficiency and beta cell loss. And 100 years experience has shown us that insulin is one agent that is capable of dropping blood sugars from any level to any level. And if you look at, as Professor Chandalia so aptly said, and Prasanna Kumar said, that the moment we look at food, this insulin starts getting secreted. And in fact, Claude Bernard in 1853 described a diabetes known as pure diabetes by interfering with the vagal stimulation of the beta cells. So all these decades and all this 100 years, we have known that insulin alone is one thing that can change the natural history of the disease. And Prasanna was just now telling us that every time ask a patient, get this insulin, take it for a month or two, you might later be on oral hypoglycemics alone. What I'm trying to say is this is one molecule that has delivered on all scores from day one when it was discovered in a crude fashion. And that did not need a revision so far. The only revision that it needed was how frequently we need to give it, how to mechanize the duration of action of this molecule. Either that regular insulin becoming a short-acting insulin or an ultra-short-acting insulin, or that proteaminized insulin getting longer and longer in the duration of action. I do not think this amylin stands a chance in combination with it in the way we currently practice. You saw the smart insulins and the smart ways of delivering insulin that are en route that Prasanna was again showing us. So this has predictably given dysglycemia. This has predictably given us a reduction in hemoglobin A1C, and this predictably will give us reduction in complications as Subhankar was just now talking about. Over to Manjunath.
Thank you so much, sir. The next question I would like to request Professor H.P. Chandalia, sir. Sir, if you're there.
Yeah, I'm there. Yeah.
Okay,
sir.
Yes, sir. Yes. So there's a question by Dr. Satish Bhatt from your presentation. I think you talked about it. So the question is, sir, you showed in one of the slides that insulin causes hypotrophy or lipoatrophy, but it's not something that doctor has seen, and he wants to know how you used to manage a case of lipoatrophy, because doctor has said that lipohypertrophy is something that he commonly sees.
Yeah. Lipoatrophy, we used to tell patients to stop injecting regularly in that site. The center, we forbid them to inject. Later on, when better insulin came, the same girl, we told her to inject at the periphery slowly with the newer insulins. See, human insulin came, and slowly it filled up. You see, regularly injecting and the same site causes lipohypertrophy, as you know, which of course is occurring even today. So what we do is we make them inject at the periphery and a different insulin, and a better insulin we used to do. When the better insulins came, first of all, we stopped them from injecting at that site when the dirty insulin was there. We forbid her then to inject there, and after that, when better insulins came, we started injecting at the periphery, and slowly it fills up to some extent. May not be as smooth a contour as the original contour, but you could at least help it partly, yeah.
Thank you so much, sir, for that response. There's a question by Dr. Srinivasan, sir. May I request Dr. Subhankar Choudhury, sir, to comment on this question. Sir, Dr. Srinivasan's comment is, thank you for sharing with us nicely about the ways to improve the adoption of insulin, but unfortunately it has still not entered the minds of patients and also our doctor colleagues. What can we do in a short span of time to improve the adoption of insulin and improve its awareness in the minds of patients? Sir, if you can please unmute.
I don't think we have a shortcut answer to that. It all lies in better education amongst us physicians and also amongst patients. And as I said, some practical tips in order to reduce the fear. I mean, it's more the fear of pen rather than actual pain that is happening. So if you demonstrate firsthand, then that's a way you gain the patient's confidence. The other is also using this more modern insulins with the lower risks of hypoglycemia. And even before that, possibly if you are following up the same patient and you decide to, usually then you decide to start on insulin when the A1Cs have not gone to 10 or 11 or 12, maybe even at HbA1c 7.5, you have to motivate, you have to make the patient understand that we have exhausted our oral agents and still it's not working. So now you need to have an insulin. And clearly starting with a basal insulin, and at that point of time you can successfully manage with basal insulin for a significant duration of time, the risks of hypoglycemia are really quite low. So you can confidently start with a basal insulin, and in course of time, when the patient gets used to taking injections, then maybe 6 months, 1 year down the line, maybe we have to take recourse to a basal plus maybe add one prandial insulin, and that may do the job. So gradually, starting slow and generally making or taking more complicated decisions later on is one way to get the patients on our side to accept insulin.
Thank you very much, sir. One last question, if I may request Dr. K.M. Prasanna Kumar sir to respond to this. So this question is by Dr. T.R. Ramaswamy. There are two parts to this question. In the first part is what can be done if we are giving both human actrapid to a patient along with Rhizodec. He wants to have your comment on if this can be done. And second thing, how do we make a choice of the insulin delivery device between the disposable and durable device that you showed for the choice of insulin initiation?
First question first. Definitely you can use actrapid along with Rhizodec. It does not mean when you use insulin, you must use only analog acid because of cost reason and other things. When you are using basal bolus dose, if you remember Rhizodec, which contains degludec, which acts for 30 to 36 hours, and contains aspart, which acts for 6 hours to 8 hours maximum. Such a situation, you can use Rhizodec in the morning. Then you see fasting is good because of degludec. Then you see pre-lunch is good, go on adjusting the dose. But post-lunch or pre-dinner is high. In such a situation, use a small dose of actrapid. So you start Rhizodec morning. If postprandial or pre-dinner is a small dose of actrapid in the afternoon. After some time, you still see HbA1c is high. Do the post-dinner. A lot of people don't do post-dinner at all. So that's why bedtime blood sugar. If the patient has taken 7:30, 8 o'clock insulin and has taken dinner, and if the bedtime blood sugar is 120, 130, nothing to worry. If it is 200, again use a small dose of actrapid before dinner. So that way you can see there is no sanctity in insulin. Whatever insulin you do, good control is better than bad control. You use the costliest insulin, most complex regime, poorly controlled. What is the use of it? So after all, insulin is a tool. What you need is wisdom. The wisdom is how to use it properly. You may have Mercedes-Benz or Maruti. If you don't know driving, Mercedes-Benz is useless compared to Maruti. So in such situation, you can use Rhizodec before breakfast, actrapid before lunch, actrapid before dinner. This becomes a basal dose because Rhizodec cannot control if you give morning, post lunch, post dinner. That is how you use it. Your next question is when to use a durable one and when to use the disposable. It's very clear. For short action, when you are using insulin at the beginning, use disposable, and because after 1 month or 2 months you are going to change it, then he says, doctor, I got a permanent durable pen, I have to throw it. No. So first when you start use a disposable pen, then once the dose is fixed, the type of insulin is fixed, then you can change over. I have already given a list of people like gestational diabetes, very old age people where the longevity of the lifespan is much less, pre-operative, post-operative, hospitalization, where you are going to use short duration of insulin, or beginning of insulin, as I told you. My favorite insulin when HbA1c is more than 11, patient says, doctor, I will take only one injection. If you give me 2 or 3, I'm going away. All right, you take one pen and take one dose because Ryzoda controls both fasting and post. So these are the situations where you use the disposable pen. When it is long duration and the insulin dose and type is already fixed, then you change over to pen.
Thank you so much, sir, for responding to that question. It is time now to give the concluding remarks to this webinar. There are still many more questions, but in the interest of time, thank you so much, Dr. Zargar, sir, Dr. K.M. Prasanna Kumar, sir, Dr. H.P. Chandalia, sir, as well as Dr. Subhankar Choudhury, sir, for nicely walking us through the history of insulins, the history of insulin delivery devices, and we could see from the personal experience of Dr. H.P. Chandalia, sir, how practice evolved over a period of time from his experience, and also Subhankar Choudhury, sir, telling us about how the adoption of insulin can be improved by breaking clinical inertia or treatment inertia. I would like to thank all the participants. We had more than 1,000 participants who had joined for today's webinar. I hope they enjoyed the sessions and it was useful to take and move towards the next century of insulin innovation and adoption. Thank you very much, everybody. Have a good night.